We're here at the ESVS Day 2, and I'm with Ron Dalman, and we're going to talk about Metformin and AAA. Good morning. Nice to meet you. I'd be grateful if you could introduce yourself to our audience.
Sure, happy to. I'm Ron Dalman. I'm Chief of Vascular Surgery at Stanford University. I'm the President-elect of the Society for Vascular Surgery, and I'm here at the ESVS meeting this year on behalf of the Society for Vascular Surgery.
So Ron, you've started looking into the study called LIMIT, which is going to look at metformin's impact on AAA. Can you just tell us a little bit about why you're proposing this study?
Yeah, absolutely. There have been for decades attempts to identify a medication which would limit the progression of abdominal aortic aneurysm disease, and a number of different agents have been tried: doxycycline, statins, propranolol, a whole range of different classes. So far, none of those medications have proven successful as an alternative surgical management. There is a need for patients, particularly identified at screening, who either are going to be too sick for surgery or aneurysms will take a long time to develop. Having an aneurysm but not being able to have it repaired surgically causes great stress, and it's been shown to make patients unhappy in the sense they know they're at risk for a problem and there's nothing can be done about it. So there's a compelling societal need for some treatment. What's different about metformin is that most of the drugs that have been proposed and trialed so far have been identified through either studying pathological specimens from open aneurysm repair or animal models. In the case of metformin, there's population health data suggesting that it's effective in preventing progression. And this is new, and its first medication has been identified through that process. So what needs to be done at this point is some type of generate level 1 evidence in a prospective randomized controlled trial to confirm that it works in non-diabetic patients.
Okay, I mean that's very, very interesting. And so metformin as a drug, obviously it's used widely in the diabetic population.
Right.
Do you see any downside for patients on metformin?
Absolutely. Every medication has side effects. Fortunately, metformin, having been used clinically worldwide for several decades, has a relatively well-known side effect profile. If you look on clinicaltrials.gov right now, there's several score clinical trials, mostly in cancer, mostly with metformin being combined with known chemotherapeutic or cytotoxic agents. So it's actually remarkably well tolerated, even in non-diabetic patients. Very infrequent that people develop hypoglycemia. The biggest issues are mostly GI issues with increased frequency of bowel movements or abdominal pain, that type of thing. And it seems to be relatively dose dependent. So I think it's actually an excellent agent to trial because the therapeutic index and the risk side effect profile is actually very acceptable, considering the fact that early aortic aneurysm patients are asymptomatic, so it's hard to make an asymptomatic patient feel better. So we want to try to use a drug which is relatively well tolerated.
Okay, and on that sort of question of dose, do you have two different ranges of dose you're going to try?
Right.
We've seen that with other drug therapies, if there's a dose-dependent effect.
Right, so that's a great question, and nobody really knows that. I think because tolerance is the main issue, our trial and a couple others which have been proposed or have started already in different areas around the world, Europe, Australia, North America, they all start with a dose ranging component where patients start, say, with 500 milligrams a day extended release metformin and then ramp up. The maximum dose is typically 2,000 milligrams a day. So in our trial, we'll move people up to the level at which they can tolerate the drug and then move on from there once we've identified what that maximum dose is. If you look again at experience of clinical trials with non-diabetic applications for metformin, the average dose per day anywhere between 1,200, 1,600 milligrams a day, something like that.
Excellent. So your trial's being submitted. You obviously have made some sort of power or estimate of what you expect to be success in the study.
Yeah.
What does that look like?
So that's an excellent point, and it depends obviously on the effect size. If you look at the retrospective analyses, depending on the size of the heterogeneity of the population that's been studied, either in very narrow or broader based populations, the effect size ranges anywhere between 30 and 75% reduction in rate of enlargement year on year. We had done some previous work suggesting that a medication for this application would only be really clinically useful if it could reduce the rate of enlargement by at least 30% or more. So our trial is powered 480 patients, we think over a course of 2 years, using a CT-determined endpoint, we should be able to identify whether or not it meets that 30% rate of reduction threshold, which we think is going to be clinically significant for this application.
Wonderful. Well, that's very exciting. I look forward to seeing that study. Hopefully you get funding. That's always the challenge, and
Yes.
good luck with that.
Thank you so much. Thank you for the opportunity. You bet.